all uveitis, and it's very easy to treat. Only you can use the topical steroid and cycloplegic and you can get rid of it. But we'll see that how the things can be little different. So here in this first slide, you can see what I have done. I have analyzed all the retrospective studies, mainly from the institute and also from the one or two from the other institute that actually analyze the various causes of uveitis. And what we see in anterior uveitis, the demographic profile that emerge out, that it's the most common of subtypes of 35 to 57% of all cases. 80% of the patients are male and 19 to 60 years of age group are involved, and mostly they are unilateral, and the most common among this anterior uveitis is acute and non-granulomatous anterior uveitis. So if you analyze the cause of this anterior uveitis in Indian scenario, we see that majority of them remain idiopathic. Among the identifiable causes, the HLA-B27 associated uveitis is very common, followed by the tuberculosis, then the viral, Fuchs and sarcoidosis. Now what we'll see here, that sometimes we need to spot the zebra in the heart, because we keep seeing the common uveitis and suddenly the presentation can be different. So we'll see how it can be. For example, this HLA-B27, what we know that this is commonly young males are involved. It's recurrent in nature. It is almost always unilateral, but keeps on alternating from one eye to another. And we see a triad of pain, redness and photophobia and high fibrin content in the anterior chamber or with hypopyon. So this is our knowledge. We'll see here another case, a 23-year-old male presented with ocular pain, diminution of vision, and diagnosed elsewhere as endogenous endophthalmitis. Now, why endogenous endophthalmitis, and the patient was advised vitrectomy? Because you can see there was a lot of inflammation in the anterior chamber, and similarly you can't see the fundus because of significant vitreous haze. So the patient, when we took history, the patient told us that he had a similar attack of redness, pain in past, and also the documentation showed that he has been treated with topical steroid and cycloplegic earlier. So now here we did the urine culture, blood culture, everything was negative, syphilis, sarcoid and TB workup was negative, but HLA-B27 was positive. The patient was treated aggressively with IVMP, and high dose of oral steroid followed by methotrexate was given, and you can see the response after a course of pulse corticosteroid. So this is, we are dealing with anterior uveitis with anterior uveitis. We have analyzed 255 cases of HLA-B27 positive uveitis, and we realized there is a subset of uveitis, almost 4%, which can present with anterior chamber inflammation and significant inflammation in the vitreous also. So you need to differentiate that, and you have to understand that, because if you do vitrectomy in such cases, for example, this is another vitrectomized eye from another hospital, and you can see the vitrectomy was done nice, but eventually everything was successful, but eventually the patient went to thusical eye. So this is another HLA-B27 uveitis, is 34-year-old lady, and third attack in a year, mainly, though the patient was on methotrexate, little subnominal dose, and you can see here the lady presented with 4 mm of mercury intraocular pressure, and you can see here it was a case of actually exudative retinal detachment. So sometimes you can actually come across this kind of unique presenting feature, and you have to be careful decoding them. So this is another literature on how the anterior uveitis can be so severe that it can present with serous retinal detachment and choroidal detachment also. Also, you have to understand this kind of picture can have the changing phase, not only this animal, but sometimes the uveitis also can change phase like this. So most commonly you see that overlap of granulomatous and non-granulomatous. For example, sarcoid is a classical example, though it can present with granulomatous uveitis, and sometimes it can present with non-granulomatous. Similarly, the viral anterior uveitis, it can run a chronic course also, or it can come with a very hyperacuate course also. So sometimes you need to spot the cat in the shadow, like sometimes we overlook the anterior uveitis. The classical example is Fuchs uveitis, most underdiagnosed and overtreated cases of uveitis. So the diagnosis actually depends on you can see the loss of fine pattern of the iris. You can't see the heterochromia, which is very evident in people with Western people. So in darker individuals, you can't appreciate that heterochromia. So you have to look for the loss of fine iris pattern, KPs and various other findings. So another anterior uveitis is that tubulointerstitial nephritis in uveitis. So this is seen in children, and sometimes you can see that by the time the patient comes to ophthalmologist, the renal parameter becomes normal. So that's why you tend to miss these cases. And sometimes you need to find out that the anterior uveitis in ship's clothing, like uncommon presentation in common anterior uveitis. For example, you see, you have to understand whenever you treat a case of anterior uveitis in children, you have to make sure that you have ruled out JIA, because JIA can be a notorious run a chronic course, and you need a rheumatologist's help to treat that. So don't treat a case of anterior uveitis only with topical steroid or cycloplegic. So what are the features of JIA? The ABC, I tell that. The A, it is often asymptomatic, white eye uveitis. It can be bilateral, often presents with band-shaped keratopathy, and run a chronic course. And so what are the tips that you have to, any case of anterior uveitis in children, you have to rule out. You have to take the history about the joint pain, and you have to send the patient to rheumatologists to build a bond with them and keep treating these children for a longer time. And you have to rely on the systemic therapy. You have to start the patient on immunosuppressive and various other conditions. And you have to, one most important, not only for the JIA patient, for every patient of anterior uveitis, you have to check the intraocular pressure regularly. So this is another patient of a 5-year-old child. You can see here, looks like an anterior uveitis, lot of exudate-like material in the anterior chamber. And when we did the UBM, you can see here there was moderately reflective seed-like echoes, more inferiorly. So these patients, when we did investigation, everything was normal limit. The AC tap was negative for the herpetic viruses also. But when we did the cytology, it showed the malignant cells. So it was a case of diffuse anterior infiltrating retinoblastoma. So sometimes this kind of condition can present with anterior uveitis. And if you miss that, then you can actually miss the child also. So another patient, you see here a 6-year-old female child, a case of acute lymphoblastic leukemia on remission. The child was doing well, suddenly presented with a hypopyon uveitis like this, and that's the time we realized that the child is having a relapse of the malignancy. And we did a AC tap, and the aqueous collected from the AC tap showed that these are not the inflammatory cells, these are the lymphoblastic cells which has come to the anterior chamber. So in leukemia patients, sometimes you can get a hypopyon. You have to make sure that these are not the inflammatory cells, or whether these are lymphoblastic cells or not. To conclude, don't always take anterior uveitis very easy one, and try to treat them empirically. And one should always should not wait for 3 attacks of non-granulomatous uveitis in every patient for starting the treatment, because sometimes the HLA-B27 uveitis, you can pick them up early, and you can explain them the recurrent nature of the inflammation, and you can actually help them to reduce the recurrence by starting the early immunosuppressive agents. And all cases of needs to go through extensive evaluation before leveling them as a idiopathic. Thank you.
Thank you, Dr. Partho, for the elegant and lucid presentation. We'll have questions. Believe me, we'll have the two-way communications. We'll have the questions at the end of the session, at the end of the talks. We have kept 15 minutes for that. I hope we'll be able to do it. Next, I'm going to talk on the structure-wise intermediate uveitis comes next. I'll be talking on intermediate uveitis and enigma. We are talking about the walk-in uveitis patients. That's what happened. It's not moving. It's not moving. Okay. Intermediate uveitis and enigma. Let me start with the case. This patient did walk in and flew from Tanzania. 46-year-old male, came to clinic with a dimness of vision. He was a known diabetic and hypertensive. He had already received 2 intravitreal injections of triamcinolone for cystoid macular edema, Diagnosed as chronic uveitis. Vision was 6.5 in the right eye and 6.9 in the left eye. Right eye was quiet. Left eye when there was a flare and cells in the vitreous. And then best-corrected visual acuity came on 13/12/2009, complained of blurred vision on the left eye. The patient had hemoglobin, glycosylated hemoglobin 11.6, and he had vitreous cells and vitreous age. And you can see the left side of the eye, left eye, has got vitreous cells almost 2+. And there was a cystoid macular edema. How do you treat a patient with 11.6 hemoglobin HbA1c? We cannot give oral steroid. So intermediate uveitis, spillover anterior uveitis with cystoid macular edema is the diagnosis. We give intravitreal Ojudex and topical steroids in the left eye. And you can see that this patient has improved significantly and all the vitritis has disappeared. And the patient got back 6 and 6 vision. We are now talking about intermediate uveitis. Some of the salient points I will highlight. It's the inflammation that predominantly involves the anterior vitreous, peripheral retina, and pars plana of the ciliary body. Pars plana is that subset of intermediate uveitis in which snowball exudates in the vitreous and snowbank formation in the pars plana seen. There is no association of systemic disease in this case. Sun working group in 2021 divided the intermediate uveitis in 3 types: pars planatis type, non-pars planatis type, and associated with the multiple sclerosis. And this is a pars planatis type. You can see the snow banking associated usually idiopathic disease. And what they complain of, any patients of uveitis complaining of floaters, you should look for vitreous cells and exudates, painless blurring of vision. Dramatic vision loss can occur when there is a vitreous hemorrhage, CME, disc edema, which is rare. Pain can be there when associated secondary glaucoma. Anterior segment quiet eye, often this is a white eye uveitis. Band-shaped keratopathy in children in particular, mild anterior chamber reaction, Martin fat keratinic precipitates you can see in the sarcoid and TB, peripheral anterior synechia, posterior synechia, secondary glaucoma. Posterior segment you see vitreous cells, anterior vitreous cells. You should focus behind the lens and you will be seeing vitreous cells and strand, mild to moderate vitreous age, snowball opacity, snow banking, retinal vasculitis may not be very obvious, peripheral retinal neovascularization, particularly in the children. And here is, I took a photograph to demonstrate that vitreous strands and opacity. These are vitreous cells. CME and its sequelae, even macular hole can be there, retinal vasculitis, retinal detachment, disc edema. Natural course of this, don't tell the patients that will be cured because self-limited is the 10%. It's mostly a chronic or recurrent disease. 60% smoldering, 30% recurrent. And these are the diseases in our country: sarcoidosis and tuberculosis to be ruled out. Multiple sclerosis is relatively rare, and Lyme disease once occurs in particular areas where Lyme is prevalent. We had a sarcoid intermediate uveitis series in Indian Journal of Ophthalmology 2022 when we have described 29 patients of sarcoid intermediate uveitis. Mean age was 42 years, bilateral majority, good results with oral steroid and immunosuppressive agents. Female were common more than the male. We also described 22 eyes of 14 cases of tubercular intermediate uveitis, which was PCR confirmed. And this is one of the examples, granulomatous uveitis with broad posterior synechia, and there was the vitreous exudates and cells, and these patients had undergone vitrectomy for the diagnostic reason, and then the vitreous aspirate on real-time PCR and nested PCR or positive for mycobacterium tuberculosis DNA. So muscular syndrome, toxocariasis, Eales disease, amyloidosis, they can mimic intermediate uveitis. This is a toxocariasis, and this is a amyloidosis which on optical vitrectomy showed congruent stain positivity with birefringence and polarizer applications. So we have primary non-familial amyloidosis of the vitreous mimicking intermediate uveitis. Vitreoretinal lymphoma, this is the most important point in the elderly particularly, and can be in the young also, can mimic intermediate uveitis. Their vitreous cells, coarse cells, much larger, and they might have the posterior segment pathology like exudates, mass lesion like aurora borealiasis. How do you work about the patient? CBC, DLC, ESR is important. We should do, I don't do chest X-ray, I do the HSCT chest, Manto to rule out tuberculosis. Serum AC, though not the best marker for sarcoidosis, should be done. Quantiferon TB gold test. And what Sun group tells that all patients of intermediate uveitis, one need to rule out syphilis. Syphilis can mimic any type of uveitis. I just show you an example, 25-year-old female, blooding of visions and floaters. Look for the vitreous cells and debris, and we could see it. Is it due to TB? Yes, it was a TB, and it was found to be HSCT chest. When you did that one, we consider parenchymal infiltrate. And real-time PCR CTAP showed 2,204 copies of the MTB DNA. Intermediate uveitis can be due to sarcoidosis. Here you can see the bilateral hilar lymphadenopathy. And the intravitreal methotrexate also we have given in intermediate uveitis associated with multiple sclerosis. And it's a rare case of multiple sclerosis showing periventricular lesion of the cerebral white matter. And there's a vitreous exudasis seen. What are the ancillary tests? FFA, UVM, and OCT. OCT is quite important to rule out cystoid macular edema. This is a 12-year-old female where you did the FFA, and you can see the capillary farming, which can be seen in a lot of intermediate uveitis cases, particularly in the periphery. In addition, there was a hot disc suggestive of inflammation. And this patient was treated with immunosuppressive agents. When you do UVM in intermediate uveitis, when the pupil is small, cataract precluding the view of the peripheral fundus, and here you can see the exudates over the pars plana showing by the arrow, and with the treatment it disappears. We can have the cystoid macular edema on fluorescent angiogram with increased macular thickness, and the guideline of the treatment is the intraocular inflammation, CME, cataract, vitreous opacity, retinal detachment, vitreous haze. Most of the cases are mild and respond to periocular steroid, and the posterior subtenon injection. First step, oral prednisolone. Second step, immunosuppressive agents. Third step, vitrectomy is in the final stage when it's recalcitrant. However, nowadays switch to immunosuppressive agents right away because due to the chronicity of the disease. These are triamcinolone acetonide given in the posterior subtenon space, and we can see that there's a video showing in the cotton bud applicator. If you apply of that on the supratemporal quadrant, there's a very little pain in the eye, and one can give the injections in the superior temporal quadrant. Bilateral cases oral steroid is required. Failed periocular injection, 1 milligram per kilogram per day, taper 10 milligram per week or 5 milligram later on. Low dose of steroid if protracted course. Immunosuppressive agents in refractory cases, I choose mycophenolate mofetil 1 gram BD, and one can use azathioprine 50 milligram TDS. Cyclosporin is not that very effective. Dexamethasone intravitreal implant has come in case of particular macular edema and recalcitrant vitreous haze, and the implant is placed in the vitreous cavity. Is a biodegradable implant, sutureless, office-based procedure. Often you can do an OT also, and there can be, this is a case of cystoid macular edema. 6 times the patient developed cystoid macular edema, responded elegantly with intravitreal Ozurdex implant. So in our experience with the 20 eyes of the 50 patients was responded very well with the treatment, and that one found to be very safe and efficacious. So this is Ozurdex implant, and it's getting degraded. Vitreoretinal surgery is intractable vitreous inflammation, vitreous opacity, membrane unresolved vitreous hemorrhage, retinal detachment, and sometimes in persistent cystoid macular edema. Cataract is another complication. Vitrectomy found to be effective when there is a recalcitrant uveitis. This is one of the cases where there is a dense vitreous opacity with exudates, and here vitrectomy will work out well. Complicated cataract can occur in that patient 7.8% 1 year, increasing to 36.6% 10 years. When do you operate? Wait at least for 3 to 6 months, best for the burnt out stage, preoperative topical, systemic, and periocular steroid, IOL in the capsular bag, foldable eyelid. In case of hypertony, you may need to combine with the pacemaker vitrectomy. So in summary, the quite common type of uveitis is the intermediate uveitis. 1 in 5 of uveitis cases is intermediate uveitis. Rule out TB and sarcoid. in the elderly, keep with primary intraocular lymphoma in mind, individualize the treatment, and prognosis is relatively good. I'd like to dedicate this talk to my mentor, Professor S.S. Badrinath, for this. Thank you. Posterior uveitis. Jyotirmay Biswas. So we'll take up the questions at the end. Second presentation. Yeah. Yeah. PGI group of the people has had a lot of studies to establish that new entity, subretinal abscess, choroidal nodule. 17-year-old girl, this patient, biopsy-proven abdominal TB, presented with the first-aid meningitis due to abdominal tuberculosis. And look at the treatment. And if you give that effect of treatment, you can see that there is a complete resolution of the lesion. This is often a one-time disease, and you can cause or have successful resolution of the disease by appropriate treatment. So diagnosis is very important. So how do you diagnose ocular signs predictive of tubercular uveitis? This is a landmark article by Professor Ahmed Gupta, which is American Journal of Ophthalmology, which showed broad-based posterior synechiae, retinal vasculitis with or without choroiditis, serpiginous-like choroiditis is tubercular uveitis type. Which lab test you will do? Mantoux and quantiferon TB gold test is supportive only. Phenotype is quite important. Exposure doesn't mean active infection. Do anterior chamber tab, vitreous aspiration, FNAB when everything is negative or you are in doubt. Subject to polymerase chain reaction for MTB genome. And I like to look at this slide. There is a 40% of the positive cases were Mantoux negative. In a AFIP study, proven tuberculosis was found to be 40% Mantoux negative. So don't depend on the Mantoux negative. Another landmark article by Somabha Basu, which showed that tuberculous serpiginous-like choroiditis can occur in patients with negative tumor TB immunoreactivity test. So don't keep in view, age-old view that you have to get Mantoux positive to have the tuberculosis. Utility of the quantiferon TB gold test in South Indian population, which we found that the combination of positive PPD test, quantiferon TB gold test, in addition to clinical presentation may be more useful. X-ray test is not enough. 40% of the tuberculosis will be missed by X-ray test. Do a high-resolution CT test. We did a study of role of high-resolution computerized tomography of the chest, and with 81% TB, 8.3% sarcoidosis was detected. And the subretinal abscess of this case is showing example of tree in the bud appearance of HSCT chest. When is the doubt, what is the role of intraocular fluid sample? You can do the PCR. Sensitivity is around 80%, specificity 100%. And here is an example of agarosal electrophotogram showing MPB64 and I6110 region positive. And this is a subretinal abscess FNAB specimen of the PCR, small tiny specimen, 0.1 ml, showed the Mycobacterium tuberculosis DNA. How to treat tubercular uveitis? Start with the 4-drug anti-tubercular therapy, always combined with the steroid at the beginning itself. I give levofloxacin instead of ethambutol to prevent the toxicity. What is the correct duration of anti-tubercular treatment? Some of the salient points I like to highlight. Treat as a neurotuberculosis and treat at least for 9 months. And what happened to this patient with the subretinal abscess? You can see appropriate treatment. There is a complete resolution of the lesion with improvement of the vision. Next comes toxoplasmosis, which was earlier the most common posterior uveitis. Is caused by the toxoplasma, and this is a congenital toxoplasmosis where nothing much you can do. And the active toxoplasmic retinochoroiditis is typical satellite lesion or headlight in the fog appearance. This atypical toxoplasma can be challenging in the diagnosis, particularly when they present with the exudative detachment or in an HIV-positive patient with diffuse multifocal de novo foci. It was treated as an viral retinitis. When it did a PCR, we found PCR of the vitreous was positive for toxoplasma. After treating with the intravitreal injection, all the retinal lesions are gone. Ocular toxoplasmosis is a clinical diagnosis. ELISA to confirm. You can start the treatment even before getting the ELISA result. PCR of the intraocular fluid in atypical cases. Now come to the next treponema, which is now emerging as a new disease. And this is 43-year-old male, dimness of vision and floaters, diagnosed as CMV retinitis, HIV positive, treated with the intravenous ganciclovir even. I shake hands with all patients routinely, particularly adults, and I found something wrong in his hands. And what else we found? I found the scaly lesions in the hands, and this was a syphilis. When you look at the fundus, we can see the subinternal limiting membrane deposits, ground glass appearance. It was RPR TPHA positive and treated with injection venlafaxine polycycline. And look at the picture, whole thing disappears and complete resolution. As I told, this is a one-time disease also. It's so gratifying to give that anti-syphilitic treatment and get the vision back. Although it was an accidental finding, our mind has to be prepared. When do you suspect syphilitic uveitis? In any uveitis, particularly atypical type, serological test, we do both VDRL to see the state of activity, FT-AVS, high degree of sensitivity and specificity. So coming to that treponema after that, viral retinitis, which is a real emergency in uveitis. This is a 30-year-old female immunocompetent teen, and this patient had got necrotizing retinitis in the posterior pole only. And look at the patient. If the room light is on, you could see on the forehead vesicles were there, and this patient has got varicose-zoster retinitis, and simple treatment with the intravenous acyclovir causes the resolution of the lesion with improvement of the vision. Viral retinitis can have myriads of protein manifestations, but this is a case of acute retinal necrosis. The patient is still in the ward. Now he was caused by the VZV virus infection and is a peripheral lesion. PORN is another type of retinal necrosis. It starts from the center to the periphery. Vessels are not involved. And this is CMV retinitis, classic Pizza-Pie appearance with vasculitis 1. When CD4 count less than 50 cells, they are fulminant form, indolent and granular type, exudative pattern. Cells more than 50 cells per cubic millimeter CD4 cell count, they can have slowly progressive granular retinitis, pan-retinal occlusive vasculitis, significant intraocular inflammation. Viral retinitis is one of the conditions where PCR is indicated to find out what type of virus. I don't want to go into the details of the treatment. ARN is treated with intravenous acyclovir, with intravitreal ganciclovir, and PORN is treated with intravenous acyclovir and intravitreal ganciclovir. And CMV is intravitreal ganciclovir, or followed by the oral valganciclovir. Last is the post-fever retinitis, which you are seeing in Indian subcontinent quite commonly. Could be dengue, chikungunya, typhoid, rickettsia, and Epstein-Barr virus. So we complete the TB, and the TB is showing that the often proteus manifestation. To treat the infection primarily, systemic steroids to control the inflammatory component, supportive anti-inflammatory therapy only. So periocular intravitreal steroids, strictly contraindicated. Intraocular fluid evaluation when in doubt. Thank you very much. So we go to the next one is the structure-wise comes the pan-uveitis, and it will be given, the talk would be given by Dr. Binita Girish Rao, who is my colleague in Shankar Netralaya, who has got enough experience in VK, sympathetic ophthalmia, etc.
Thank you, sir. Good evening, everyone. I'll be speaking on pan-uveitis. The International Uveitis Study Group has described the definition of pan-uveitis as a generalized inflammation of all three parts of the uvea, the iris, ciliary body, and the choroid. So the evidence for the choroidal inflammation can be any of these things, choroiditis, retinochoroiditis, or necrotizing retinitis. And it also includes vitritis and anterior uveitis. There can be many pan-uveitic entities, and like any uveitis, the diagnosis is based on a careful history, examination, and tailored investigations. Let us look at one of the most common entities of panuveitis which comes to our clinic, the VKH disease. It is a severe bilateral granulomatous panuveitis with extraocular manifestations involving the central nervous system, auditory system, and the integumentary system. It is a T lymphocyte mediated autoimmune process against the choroidal melanocytes. The trigger is believed to be a cutaneous injury or a viral infection which causes sensitization to the melanocytic antigens. The exact target antigen is not known, but it is believed to be a tyrosinase related protein or a 75 kDa protein or the S100 protein. It is usually seen in the 20 to 50 years age group, women and Asians being more commonly affected. If the patient comes to you in the early stages of the disease, they usually come with complaints of headache, and the ocular features you see are an exudative retinal detachment. It may be either a focal, multifocal, or a bullous RD. And depending upon the severity of the disease, they may have optic disc hyperemia and edema. Usually the disease is bilateral, but at the time of presentation, it may be asymmetric. If the patient presents several weeks or months later with poorly controlled disease, then they may have features of ocular hypopigmentation in the form of a sunset glow fundus. You can see the RP defects here and the complications like subretinal gliosis and pigment migrations and complications of cataract and glaucoma. They may also have features of cutaneous hypopigmentation like vitiligo and poliosis and alopecia. Now, since VKH is a choroidal disease, ICG is a very important method of investigation. You can see the hypofluorescent dark dots of ICG showing the choroidal granulomas much better than the FFA. Now, the FFA is also useful to pick out the pinpoint leaks in the early stages with the late pooling of the dye in the form of lobules. And you can see the hypofluorescent rim of these lobules, which are suggestive of the septae between the lobules. ICG also shows the fuzzy choroidal vessels and the late hyperfluorescence of the inflamed choroid. CSR is one of the very important differential diagnosis of VKH disease, especially if it comes in the early stages. And you can see in the OCT here how clear the vitreous is in the CSR with a smooth RPE, whereas you can see the RP undulations, the choroidal thickening and the elongation of the outer nuclear layer in the VKH, and the vitreous cells which are there in VKH with the turbid subretinal fluid and the, what we call the bacillary layer detachment here. The multimodal imaging in VKH is also very useful, not only in the diagnosis but also in the follow-up of the disease. You can see the hyperfluorescent, the hyperautofluorescence in the active disease, which normalizes after treatment. And the hypofluorescent dark dots on ICG co-localize very well with the flowoid areas on OCTA. And the SSOCT is also very important in picking up the septate subretinal fluids and the choroidal thickness, which dramatically improves with treatment. There's some of the rare complications are neovascularization of the disc, which we saw in this patient of VKH, and some CNVM. Now, a large number of patients can undergo remission and cure before depigmentation occurs if there is early initiation of therapy. Given that the window period is about 2 to 3 weeks following the disease onset, if you treat them with a combination of steroids and non-steroidal immunosuppressives. But remember that as the disease resolves, there can be subclinical choroiditis, which you can monitor with ICG if possible. Because if you miss this window period, then the patients can go into a chronic VKH, which is not prone to remission and can have ocular and extraocular complications. Sympathetic ophthalmia is a very important disease which resembles VKH very much, but the most important difference is that it occurs after penetrating injury. A very significant landmark paper was presented in the year 2000 by Kilmartin and co-authors. It was a population-based study, and at that time the prevalence rate was around 0.3 per 100,000 per year, but now the incidence has reduced considerably. This also has similar features like VKH with vitritis, exudative retinal detachment, but the systemic features appear to be less common. The FFA sometimes shows the starry sky appearance, and hot disc means that it's an inflamed eye. This is a rare case of sympathetic ophthalmia presenting signs of frosted branch gingivitis, which was published by Dr. Biswas. The best way to manage sympathetic ophthalmia is a prompt wound closure and a good wound closure. Enucleation of the injured blind eye within 2 weeks can help in reducing the incidence. But once the disease process is apparent, enucleation is controversial. In the present day scenario, the incidence of sympathetic ophthalmia from penetrating injury is decreasing, but there is a debate whether it is increasing following vitreoretinal surgery or whether the antecedent trauma is making the difference or not. The study from Kilmartin also confirmed that a good visual prognosis is related to prompt and adequate systemic immunosuppression. And one of the more recent studies by Dr. Partho Majumdar on pediatric sympathetic ophthalmia also showed that the visual outcome even in children is very good, with them achieving 612 or better vision in 70% of the sympathizing eye. Behçet's disease is common amongst the Japanese patients, who show more than 58% of the Japanese patients have complete Behçet's with HLA-B51 positivity. What is important to remember is that the uveitis in Behçet's disease follows the onset of oral and genital ulcers by a few years. They present with bilateral iridocyclitis with or without hypopia and vitritis, but they also have obliterative retinal vasculitis, which rapidly progresses to optic atrophy. This was a rare case of atypical Behçet's disease, which we saw. As you can see here, the patient had a completely quiet eye and there was nothing in the fundus, with just a macular hole. But somewhere in the periphery, he had a small segment of vasculitis, vascular sheathing, which prompted us to do the FFA, and then we saw extensive capillary leaks, and the patient also happened to have HLA-B51 positivity and oral and genital ulcers. And as you can see, this is not pathognomonic, but very often seen in Behçet's disease, this Ferning pattern. Sarcoid disease is uncommon amongst the Asian Indians, but presence of panuveitis is seen in about 6 to 33 patients of sarcoidosis, and the presence of panuveitis is considered as a poor prognostic factor in these patients. The International Workshop on Ocular Sarcoidosis defined certain criteria for it: the mutton fat keratic precipitates, the vitreous snowballs, the peripheral multifocal choroiditis, the disc nodules and granuloma, the nodular and segmental periphlebitis, and the candle wax drippings. And they also included the negative tuberculin test, the elevated serum ACE levels, the chest X-ray, and the abnormal CT scan. But the diagnostic test in all of these is if you can demonstrate a non-caseating granuloma from a tissue biopsy, like the skin biopsy. So a biopsy proven with a compatible uveitis is needed for a definitive ocular sarcoidosis diagnosis. Sometimes OCTA can pick up these small phlovoid areas of the granuloma, which resolve well with treatment. Tuberculous uveitis has already been spoken elegantly by Dr. Biswas. I'd just like to say that the tuberculous uveitis is a secondary disease and may be either direct Mycobacterium infection or a hypersensitivity reaction. And a large study on ocular tuberculosis from India showed that panuveitis is about 11% in all cases of ocular tuberculosis. As he already said, there is it presents with a myriad of features like granulomatous anterior uveitis, solitary or multiple choroidal nodules, neuroretinitis, subretinal abscess, focal and multifocal choroiditis. And the diagnosis depends upon various things like the migration from an endemic area, the history of contact, the suggestive ocular findings, along with a positive TST and a positive response to a ATT. So we need to basically rule out masquerades and infectious uveitis before we treat these patients with steroids, immunosuppressives, and more recently in refractory cases, they will need biologics also. Thank you.
Thank you, Dr. Binita, for the elegant talk and highlighting various salient points of panuveitis and sticking to the time. We will have some time for the question. Now we invite Dr. Somabha Bosu, who has done pioneering work in tuberculosis, particularly tubercular uveitis and tubercular retinal vasculitis. We are very proud of him, and I like to call upon and to talk on retinal vasculitis stepwise investigations and management. This will be very practical tips.
Thank you, sir. Thanks for allowing me to speak on this forum. So why is retinal vasculitis so important? It's one of the commonest forms of uveitis. Up to 10% of all uveitis that we see in our clinics are primary retinal vasculitis, and a substantial number of other uveitis entities also have a secondary retinal vasculitis. So it's a very common entity. And it is quite different from systemic vasculitis, because unlike systemic vasculitis, if you speak to our rheumatology colleagues, they'll tell you that they need a histopathological diagnosis to call it vasculitis. On the other hand, we do not have that, but we can directly see the disease, which our rheumatology or other colleagues in other specialties can't do. Directly see the retinal vasculitis in the patient, and that's a huge advantage. Now, here are 2 points that I want to emphasize very much. One is that retinal vasculitis is very frequently associated with systemic infections or systemic disease. And this is different from the fact that it is rarely associated with systemic vasculitis. So all the things that rheumatologists deal with, the ANCA-associated vasculitis, etc., those do not cause retinal vasculitis. If you want to look at the literature, you should look at Professor Rosenbaum's studies to verify this fact. So testing for ANCA, for ANA, in patients who do not have any systemic disease of ANCA or ANA is a very futile exercise. Now, how do we go about looking at these patients? First, find out what type of vessel is involved. Is it the arteriole or the veins or both? What are the sizes of the vessels, mainly the capillaries or the medium or larger vessels? What are the morphology of the infiltrates? And I'll come to it in a while. And once you have characterized the vasculitis, see what are the other ocular signs and what are the other systemic signs in the patient. So when it comes to the type of vessels, most retinal vasculitis that you will be seeing in your clinic will be involving the veins. They are periphlebitis, and the 2 conditions that are commonly associated with periphlebitis are TB and sarcoid. And these are probably the most common causes of vasculitis that you may be able to pick out. Behçet's can also cause primary retinal periphlebitis. Arteriolar involvement is mainly seen in the infectious retinitis, for example, viral retinitis or toxoplasma retinitis. These are secondary arterial involvements. Then some of you might be familiar with this condition called as IRWAN, where you see retinal arteriolar macroaneurysms. And in those rare cases where SLE or polyarteritis nodosa cause retinal vasculitis, you may see arteriolar involvement. Similarly, the ANCA-associated vasculitis, when those very rare cases where the retina is involved, will cause a mixed arteriolar and venous involvement. Behçet's can also cause that. Now, what are the different morphologies? See, these whatever I'm discussing so far, they do not need any kind of lab test. This is just what you're seeing in the patient. So what are the different morphologies you can get depending on the severity of the inflammation? You can get skip vasculitis, or you can get an confluent area of vasculitis. Then there are other patterns like frosted branch angiitis. You just saw some pictures, Chiariles vasculitis, occlusive vasculopathy, and IRWAN, and let's go through some of these. So you can see this is a confluent vasculitis which shows the severity of the inflammation in this patient, whereas in the infranasal quadrant you see this is a skip vasculitis, a small area of inflammation. This is a classic picture of frosted branch angiitis. This is Chiariles vasculitis, which you see here. I've picked up from this small part, and you can see these are intraluminal opacifications, which you can see here. They do not represent active inflammation. Instead, they come up when the retinitis, which could be due to toxo or TB or CMV, when that is resolving, that is the stage when you see this kind of Chiariles vasculitis. Occlusive vasculopathy. Now, as you can make out from the name, this is not a vasculitis, so you do not see any perivascular exudation, but there is a vasculopathy, and one example is Takayasu's arthritis, where there is no perivascular exudation, but huge retinal hypoperfusion. You can see almost the entire retina is without capillaries. Another cause of occlusive vasculopathy, in this case, Aplar syndrome in SLE, and you may also see those rare cases of Suzak syndrome causing occlusive vasculopathy. So no exudation, but huge hypoperfusion. You can see this in the FFA here. This is one condition that you come across very rarely, idiopathic retinal vasculitis, aneurysms and neuroretinitis, short IR1, more common in females. But apart from the macroaneurysms, which I'll just show you, what is very characteristic is this huge macular star or exudation. And this is the most common cause of loss of vision and very refractile to treatment in these patients. And this is what we deal with in the clinics. And also there is this, these might be healed, as can be seen here. If you see lesions like this on a blood vessel along with retinal vasculitis in a TB endemic country like India, you're almost sure that you're dealing with tuberculosis, irrespective of what the test results show you. Then occlusive vasculitis, TB more likely than sarcoid, and you cannot get away from there. These are features of sarcoid that you should look for in patient of retinal vasculitis. In the inferior and nasal fundus, you typically see these discrete hypopigmented spots, and in the anterior segment, you may find the granulomatous anterior-uveitis with peripheral anterior synechium. Behçet's disease, you see this either a capillary involvement with a retinitis seen here, or a typical retinal periphlebitis as seen in the right eye of this patient. When you do the angiogram, you just heard about how you see the ferning of these vessels. An important point to stress here is that Behçet's is not diagnosed by testing for HLA-B51, because as you just heard in the previous talk, up to 40% of Behçet's patients can be negative for B51, and up to 30% of the normal population can be positive for B51. So B51 is not a diagnostic test for Behçet. Instead, the diagnostic criteria include the ocular features and the systemic features, especially the ulceration of the oral and the genital regions. So this is seen here in this picture. There's no mention of B51 in these criteria. These are secondary vasculitis to infectious retinitis. This is toxoplasma seen here. You can see this one happening. You just treat the toxoplasma, it goes away completely. This is secondary to acute retinal necrosis. You see the tongue-shaped extension of the acute retinal necrosis here. So how do you combine all of these to reach an etiological diagnosis? We start with cases or sometimes pars plana vitrectomy to deal with the complications. This is one case that required just anti-TB therapy, and you can see the picture after 4 months of anti-TB therapy, which shows that this is not any kind of hypersensitivity reaction. This is a pure infection of the retina that causes the TB retinal vasculitis. So to summarize, the retinal vasculitis is caused both by infections and systemic diseases, but rarely by systemic vasculitis. You look at the type of vessel, size, morphology, associated ocular and systemic signs, characterize the morphological appearances and the associated ocular signs to reach the diagnosis and treat the inflammation and the complications. Thank you very much for your attention.
Now we come to a very important talk, and this would be very valuable for the general ophthalmologist. Which patient and when should we refer to a uveitis specialist? This talk would be given by none other than Dr. Bishali Gupta, who is the professor of retina vitreous as well as uveitis from Advanced Eye Care Center, PGI, Chandigarh. Dr. Bishali Gupta, please. No, not at the end. We'll have a lot of questions.
Thank you. Thank you, Dr. Biswas. My topic is very straightforward. Which patient and when should you refer to a uveitis specialist? This is mainly for the comprehensive ophthalmologist, and it starts with the clinical scenarios. The first is that I look at the patient and I do understand that what I'm looking at is potentially devastating disease, which needs very aggressive management as well as the close monitoring of the complications. So I think this would be the first scenario when I would consult a uveitis specialist, because if I do not, right from the beginning, it might result in lot of complications and ocular morbidity. This is one such example. This is acute retinal necrosis. And these days we are seeing the acute retinal necrosis, which is post-COVID very fulminant, and it's behaving a bit differently with high viral load. So it's better to get it to a higher center right in the beginning rather than trying some antiviral and then, ending up with the complications. The second is I look at the patient and somehow my sixth sense tells me, or my clinical acumen tells me, that it could be a lymphoma, it could be malignancy, or it could be metastasis. This is one such example. You see a patient coming with these deposits, These are, you will find something is deposited in the subretinal space. It's neither retinitis nor choroiditis. Or you may have these small orangish nodules and they look something different. I do not know what it is, but I think it could be lymphoma. It is best to refer this patient at this point of time and not to start on steroids, because the problem is patient will respond to steroids, but when ultimately the biopsy is done, it will come out to be negative. So the diagnosis of lymphoma will be delayed. So if suspected, please refer it at this point. The third is I just look at the patient and I do not know what it is. And believe me, it happens. At least it happens with me. I look at it, I said, I don't know what it is. But if you are not in a uveitis setting and you don't have a paraphernalia to figure out what it is best to send that patient to someone who could. For example, this young boy. I'm not going into the details, but this is what you see in SSPE, the patient who has not received measles vaccines. These are not the cases you will see every day, but if you see something which you just don't understand, please do not start empirical or presumptive therapy. Because we do situations like this where people say Monteus is positive. What will Monteus do? Monteus is not even required. So don't go off the track and just, say that I don't know, I need to refer the patient. The fourth is patient is under my care, but patient is not responding to the treatment the way I anticipated. For example, this is the patient. On top it shows it's a TB serpiginous like choroiditis. Fine. I started the patient on treatment, and the bottom picture shows that while on ATT and some steroids, the patient is worsening. There are new lesions appearing. So there are a lot of questions in my mind at this point of time. Should I stop ATT? Should I reinvestigate the patient? Should I increase steroids? Should I stop steroids? These are multiple questions a comprehensive ophthalmologist would have. So this is just to show the course of the disease. We have tried so many things, but my point here is if the patient is worsening on therapy, please refer it to a uveitis expert who can figure it out what to do. The fifth is patient is having multiple recurrences every time I reduce steroids, and from where I am, I see a lot of referral, and I do see the hesitation on part of comprehensive ophthalmologists to give high-dose steroids and to give it for a longer time. So what happens typically? The first day you see the patient, you write 50 milligram for 1 week, 40 for 1 week, 20 for 1 week, and done with it. That is very bad actually for uveitis because it tends to keep coming back again and again. So if ever I am in a situation like this, or I have a patient who is in a condition where I anticipate will need a long-term immunosuppression, even if you have not referred the patient initially, but if you think patient is having recurrences, needs immunosuppressive, please refer it at that point of time. And a typical example is VKH and sympathetic ophthalmia. There is no way a patient of VKH will be free of recurrences with steroids alone. They will respond, you will get good results, but they will keep coming back again and again. And every time there is a recurrence, there is a residual morbidity in the eye. So please refer them at the first go, if not at the time of recurrences. Sixth, this patient is not having a typical phenotype, and I'm confused what I'm dealing with. For example, this is the patient who has few vitreous cells and has like this. So I do see patients referred as retinitis pigmentosa with vitritis. There's nothing like that. The patients with dystrophies and degenerations are going to have few vitreous cells. So if you are confused, if you think there is an intermediate uveitis happening in the backdrop of dystrophy, please refer this patient to a higher center, because this is the patient with CRB1 mutation that was being treated as uveitis. Seventh is I am unable to make up my mind whether it is uveitis or endogenous endophthalmitis. And that can cost very heavily to the patient because the treatment are very, very different. For example, this patient, somebody was managing it as retinitis, and it was actually, he had silicone oil in his eye, and I don't know how somebody made the diagnosis of reactivation of acute retinal necrosis in a silicone-filled eye, and this was actually a fungal endophthalmitis, an abscess arising from the scleral buccal which kept on growing under this, and that is the calcofleur showing the fungus. Pediatric uveitis, don't ever, it's very tough even for the uveitis experts. So never ever, treat children if you do not have the paraphernalia. Please refer, please do not start them on steroids. We do have very good drugs, biologics and all, which should be given initially. For example, this looks like, one more minute, Dr. Biswas.
Yes, sure.
This looks like anterior uveitis in a child, but actually it's a case of TINU, and then we have Blau, and we have lots of things which need very aggressive therapy. So please do not just think that children have a very minimal anterior uveitis and you can treat, because that's a very different ballgame altogether. Or they could have masquerades, for example, a hypopyon in a child. It's never due to inflammation. It's mostly due to masquerades which include leukemias and sometimes retinoblastomas. Geriatric uveitis. Masquerades need to be ruled out. If a person of 70 years comes to you with the uveitis for the first time in the eye, don't ever think about it, just refer to the higher center, because autoimmune disease does not come for the first time at the age of late 60s or 70s. Example is this lady, some vitritis and autofluorescence shows this leopard skin, it is actually lymphoma. And last, if you plan to do cataract surgery in a uveitis patient who looks quiet to you today, you may have seen the patient for the first time at this point, and we all love doing surgeries, and as a surgeon, we just want to shift them to OR and put an implant. But you have to resist that urge or the itch. It's important to involve your uveitis expert for the good evaluation and make this eye quiet under his supervision for the next 3 to 6 months. And this is how you should refer. So to conclude, please refer whenever you are not too sure of the things, because there is no ego involved in referring. Thank you very much, Dr. Biswas.
Thank you, Dr. Bishali, giving us the pulse of management and diagnosis of uveitis, so in the general ophthalmologists need to refer. Actually, I wanted that almost like similar thoughts in my mind, and you really echoed my thoughts. Lot of the uveitis patients, when they should be referred, is not referred and lose vision. And I know that